My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Hello and welcome to Coag Conversations, an educational series sponsored by Biomedica Diagnostics of Windsor, Nova Scotia, Canada. Our topic for this series is trauma-induced coagulopathy, mechanisms, management, and the laboratory's contribution. I'm George Fritzma, faculty for the University of Alabama at Birmingham School of Medicine, Division of Laboratory Medicine, and proprietor of the Fritzma Factor, your interactive hemostasis resource, where we exchange current information on coagulation mechanisms, clinical observations, and the role of the laboratory in diagnosis and management of disorders. It's my pleasure to introduce our guest, Dr. Maureen Hoffman. Dr. Hoffman's research focuses on the role of cellular features in controlling hemostasis and thrombosis. Her collaboration with Drs. Mac Monroe and Harold Roberts led to the development of an in vitro cell-based model that mimics many aspects of hemostasis in vivo. Their work has clarified why the deficiency of factor VIII or factor IX in hemophilia leads to such a severe bleeding tendency, and how hemostatic agents such as prothrombin complex concentrates and the recombinant activated factor VII enhance thrombin generation. Dr. Hoffman has clinical interests in component and pharmacologic therapies for bleeding disorders and laboratory monitoring of anticoagulants and transfusion therapy. Dr. Hoffman obtained her MD and her PhD in pharmacology and toxicology from the University of Iowa. She completed residency training in anatomic and clinical pathology at Duke University in Durham, North Carolina. Dr. Hoffman's current position is as professor of pathology at Duke University and director of the transfusion service and core laboratories at the affiliated Durham VA Medical Center. She has authored or co-authored over 200 journal articles and 15 book chapters, and has lectured extensively in the U.S. and internationally on basic and clinical laboratory aspects of coagulation. She was recently honored with an esteemed career award from the International Society on Thrombosis and Hemostasis. We begin today with a review of the mechanisms behind the hemorrhagic and thrombotic outcomes of trauma. Dr. Hoffman, please describe briefly the world and U.S. incidence of accidental trauma.
Well, first of all, I'd like to say that it's a pleasure to be able to join you today. Trauma is a serious issue in the United States and around the world. In the United States, it's the leading cause of death for people in the age group between 1 and 46. And worldwide, it's second only to infectious disease. So not only does trauma take a lot of lives, but especially since it affects younger people, it impacts a lot of years of life, potential years of life, as well as costing a lot of money to manage and deal with. So trauma is a very important topic, and unfortunately, we don't fully understand the mechanisms of the coagulopathy that goes along with it. But we are gathering more information and beginning to have an understanding of the different facets of coagulopathy in trauma.
Oh, good. That was going to be my next question, a good lead in. So is there a single mechanism that accounts for the mortality while in hospital care of trauma victims?
Well, the short answer is no. However, I think we have defined some of the factors that contribute to the coagulopathy, first bleeding and later thrombosis that can occur following trauma. And I'd like to share a couple of graphics as we go on to discuss these ideas. So this first figure is more, I guess, conceptual than truly mechanistic. Trauma-induced coagulopathy is not purely a hypocoagulable or bleeding disorder. Initially, in many instances of trauma, bleeding is the problem, and a lot of the early mortality attendant to trauma is due to blood loss. So in the early period after trauma, both before the victim is transported to some medical treatment facility and early after arriving there, the body is making a response to the injury. And that injury leads to the activation of coagulation. If everything goes well, the body is up to the challenge and bleeding stops. But factors are consumed and there's a huge demand on the hemostatic system. During the process of trying to respond to what may be massive hemorrhage, dysfunctional features to coagulation can occur, and they're indicated in the light green boxes in this figure. So near the center of the figure, first, decreased thrombin generation can result as factors are consumed, or as some of the mechanisms that we'll talk about in just a moment deplete or degrade coagulation factors. Fibrinogen forms the structure of the clot, and so it is depleted even more than the enzymatic factors because it's actually used to plug the holes. And relatively small decreases in fibrinogen can impair the integrity of the clots that are formed. We don't fully know the mechanisms, but platelet dysfunction can develop in the acute phase following injury. Some of that may be because the platelets are activated by a variety of mechanisms, and even if they don't participate in clot formation, they become dysfunctional because their reserves have been depleted. That is, they're refractory to further activation. Also, whenever a fibrin clot forms, the process of fibrinolysis is activated. And that's important. It balances the formation of clots and prevents fibrin clot formation from spreading into healthy or at least intact vessels. But because fibrinolysis becomes activated fairly early on in the process, if a patient continues to bleed and hemostasis isn't established, hyperfibrinolysis can ensue, or at least locally hyperactive fibrinolysis, because the fibrinolytic enzymes are activated at the site of injury. And if a clot doesn't stop bleeding, more hemostatic clot has to form in the presence of plasmin activity, in the presence of fibrinolysis. So all these things can contribute to a bleeding phenotype. It's not just the trauma itself, though certainly having big holes in vessels leads to bleeding. But the hemostatic apparatus becomes dysfunctional early on, and the degree of that dysfunction has some rough correlation with the degree of tissue injury during trauma. On the other hand, during the response to injury, inflammation is triggered. So inflammatory cells infiltrate an area of tissue damage. This is important because they're going to deal with invading organisms and foreign debris. And anytime there's tissue injury, components are released that trigger or enhance the inflammatory response. Inflammation is associated with a hypercoagulable state. And There can be an element of increased thrombin generation. Fibrinogen is an acute phase reactant. Over time, fibrinogen production increases. Inflammation tends to activate platelets as well. So all of these factors can contribute to a thrombotic phenotype. During the very early stages of coagulation or the response to injury, the bleeding phenotype tends to predominate, although they're fairly early on, there can be a component of hypercoagulability. This may be appropriate because the body's trying to respond to all this tissue injury. But in general, what tends to happen is that early in the response to injury, coagulation is activated and then components are depleted and bleeding continues. Over time, usually more than a day after the injury, the inflammatory prothrombotic phenotype tends to predominate. So someone may be admitted to the hospital with bleeding and be massively transfused, and then at some point that we don't have a good way to predict or detect, this inflammatory phenotype tends to take over, and they may then suffer thrombosis. So these are the general concepts that we should think about when we try to think about how trauma-induced coagulopathy occurs. So let's take a look at some of the specific mechanisms that are involved. So these are some more detailed mechanistic features that contribute to both the hypo, again indicated in the green color, and the hypercoagulability that can develop following trauma. So certainly when there's injury and blood loss, hypoperfusion can develop. Early on, that can tend to exacerbate the bleeding tendency, the hypocoagulable state. And later on, hypoperfusion can lead to increased inflammation and exacerbate the thrombotic state. Tissue injury is a major factor in promoting the prothrombotic state that develops later. A number of components released from cells, including histones, DNA, and procoagulants, cellular procoagulants, can promote inflammation and promote thrombosis. Endothelial cells are really key to a lot of the response to trauma. Endothelial cells become activated. They release procoagulant factors, such as von Willebrand's factor. They also tend to lose their anticoagulant function and can promote a prothrombotic state, promote platelet activation. They also, however, can lose their barrier function and allow the leakage of fluids out of the vasculature. So there are a lot of inflammatory components that become activated. And when there's greater injury, especially when there's traumatic brain injury, there is more inflammation, there's more procoagulant released, and many more of these mechanisms that become engaged to a more intense degree. So we do know a number of specific mechanisms, and I'm not going to go through all of these in the interest of time. We do know a number of mechanisms that contribute to both the bleeding and the thrombosis following trauma. The problem is that trauma is, I guess you might say, hopelessly heterogeneous. Everybody's got their own kind of injury. And while we can separate injuries into categories such as blunt or penetrating trauma, not all penetrating trauma is equally damaging. Blunt trauma varies dramatically from the elderly fellow who, on an anticoagulant that falls off the ladder, to the soldier that steps on an improvised explosive device. So one of the difficulties in studying these mechanisms is that the degree of tissue damage and the site of tissue damage varies tremendously between patients. So it's hard to get a uniform population in terms of the kind of injury. In addition, different individuals respond very differently. So in military trauma, basically everybody's a young, otherwise healthy, fit individual. And so that's been a good platform for some of the studies that have been done. But in civilian life, the variety of people that suffer trauma is tremendous. And so that has been a big impediment to doing real rigorous studies on management of trauma.
So I guess you would say a lot of this has to do with the activation of the endothelial cells, as you mentioned, secreting von Willebrand factor and various cytokines. And are the cells like platelets, neutrophils, and monocytes are also participating in the trauma-induced coagulopathy?
Yes. So this figure illustrates a little bit of the interactions between some of the key cells in the response to trauma. Certainly, endothelial cells are central to the whole process. They are very responsive to local conditions. They actively secrete, as you can see up here in the left-hand corner of this, von Willebrand's factor, and also they serve as a site for platelets to bind. They can increase their adhesive molecule expression and promote clot formation. So these are all adaptive responses. These are all things that the body needs to do. And in addition, the inflammatory cells, such as the neutrophils pictured here, and also monocytes, localize to a site of injury. And neutrophils release nucleic acids and form these so-called nets that participate in promoting activation of coagulation and also mitigating infectious issues. This is a very pro-inflammatory milieu. And so these cells, monocytes and neutrophils, that play important roles in inflammation and antimicrobial activity, also are key players in moving this whole process over into the maladaptive phase.
I want to ask a leading question.
Sure.
I know it would be difficult to say there's one particular mechanism that is the major culprit. I've been hearing quite a bit about von Willebrand factor and ADAMTS13 levels. Would you say that that's a major contributor, or is it just part of the overall milieu?
It's hard for me to sort one. I mean, I think all the things that endothelial cells do as a group are more major. Von Willebrand factor certainly contributes, but if I had to say something that was central, I would say the endothelial cell, including release of von Willebrand factor, is really critical. Endothelial cells become dysfunctional in the maladaptive response to trauma. And some of that is releasing the ultra-high molecular weight forms of von Willebrand factor, which participate in forming micro and macrovascular thrombi. But also the endothelial cells shed some of their surface molecules that are not just decoration, but very important functionally. So these molecules tend to be anticoagulant. So things like heparin-like molecules are normally present on endothelial cells. And so losing those changes the character of the endothelial lining. And endothelial cells also express adhesive molecules that then facilitate the binding of all these other cells and components. So I think von Willebrand's factor is important, but I guess this is my bias. I tend to see the cells as key players even more than any individual protein.
Thank you. And one last question about mechanism. Most of us, when we think of trauma-induced coagulopathy, we think about hemorrhage and bleeding, managing the hemorrhage in various ways that we'll talk about later. However, what's going on from a mechanism point of view when switching from a hemorrhagic to a thrombotic picture?
Well, I think of the body's response to trauma or any kind of injury as being a spectrum of activities. So blood coagulation is the first, I would say the first response. Almost coincident with that is the influx of acute inflammatory cells, neutrophils. But over time, assuming the person survives the initial injury, over time, the response has to shift to dealing with the damage that has occurred and then repairing the damage. And that, by and large, has a strong inflammatory component. And along with that inflammatory component is a procoagulant component. And so what tends to happen is that early on, bleeding is a problem, and most early death following injury is related to bleeding. But as the inflammatory, immune, reparative mechanisms take hold, that's when that thrombotic tendency develops. And we can transfuse somebody, and see this fairly frequently, get someone through the initial 24 hours after injury, apparently successfully, only to not deal tremendously well with the thrombotic consequences that follow in the few days later. And the extent to which the pro-inflammatory and thrombotic environment develops and the amount of thrombosis that happens depends on factors related to the injury itself, say the amount of tissue damage that's been done. So in large-scale blunt force, like a blast injury, there's a lot of tissue injury. And that's a lot of impetus for inflammation and therefore thrombosis. But another component is different people respond differently. And one of the big challenges in managing trauma is determining when the problem switches from being a bleeding problem to being a clotting inflammatory problem, and then dealing with that. But again, you don't feel very good about anticoagulating somebody who just stopped massively bleeding. So it's a very difficult transition to make, and we don't truly have a satisfactory way of identifying those people who would benefit from an earlier transition to management of thrombosis.
Thank you. I did think of one more question.
By all means.
Does traumatic brain injury in any way shift the balance in one direction or another?
Yeah, absolutely. Traumatic brain injury deserves to be sort of in a category by itself. In that case, there are release of cellular components, including microvesicles, that are very procoagulant. And so traumatic brain injury is one of those types of injury where a procoagulant component appears very early. Now, that doesn't mean they're not bleeding also, but they can have more of a DIC-like picture. So the trauma-induced coagulopathy is not the same as DIC in general, but some people with trauma can have DIC. And in the case of traumatic brain injury, DIC can occur, and there's a much more prothrombotic profile, I guess you'd say, as well, very early on because of the procoagulants released from the brain. And so those folks may need to be observed for prothrombotic, pro-inflammatory events much earlier than people who don't have a significant component of traumatic brain injury.
Thank you, Dr. Hoffman. This concludes our first conversation. Dr. Hoffman, thank you again for your expertise. We encourage participant questions and comments, and there's a link on the Biomedica Diagnostics website for you to download a transcript of today's talk and forward your questions or your comments. Please join us next month for conversation number 2, entitled Management of Trauma-Induced Coagulopathy. Thanks to Biomedica Diagnostics for sponsoring COAG Conversations, and thank you for your participation.